Thank you very much. Good evening, everybody. My name is Oliver Morgan. I'm the director of the Department of Pandemic and Epidemic Intelligence Systems here at the WHO Hub for Pandemic and Epidemic Intelligence. It's a pleasure to be with you tonight. I actually convey my apologies from Dr. Chikwe Ikweazu, who is the Deputy Executive Director of the Emergencies Program. Unfortunately, he was called away for a family matter, but he does send his best wishes to everybody and regrets not being able to be with you in person tonight. So good evening, everybody, and thanks a lot for joining. Tonight is the 9th edition of our speaker series. I also like to extend a warm welcome to everybody who's joining us online. We're live streamed, and this event is also available to watch after as a recorded session. And with us in the speaker series tonight, we're delighted to welcome many policymakers from several German ministries, including the Ministry of Health, Ministry of Education and Research, Ministry for Economic Cooperation and Development, the Foreign Office, and members of the Federal Parliament. Welcome. We're also delighted to have with us many thought leaders from German as well as international academic institutions. And I would also like to acknowledge our collaborators from the Charité Center for Global Health in particular, which is one of the world's leading institutions in medical research and education. The Charité University is our first collaborator and was the first collaborator in our inaugural speaker series in July 2022 and has been an invaluable partner ever since. So for those of you who may be newer to the Hub, the WHO Hub was established in September 2021 and has rapidly become part of the global health ecosystem here in Berlin. We bring together innovators, scientists, and experts to advance the field of pandemic and epidemic intelligence. At the core of the Hub is a multidisciplinary and multi-sectoral approach, integrating perspectives across human, animal, and planetary health, alongside expertise in social science, data science, pathogenomics, and other many exciting areas. Just before tonight's event, we are also delighted to host an open house event for those of you who could make it here in Berlin. And we welcomed more than 100 guests to meet many of our colleagues who are here working in the Hub and to learn about our diverse portfolio of work. We've also enjoyed thought-provoking presentations this afternoon by PhD students from the Global Health Program in collaboration with 7 Berlin-based universities, which we are also glad to support as the Hub. Tonight, we're privileged to hear from an inspiring panel of speakers about the role of research in pandemic and epidemic intelligence, a critical topic that underscores the importance of robust research for effective surveillance and evidence-based decision-making during public health emergencies. So proceeding to the official opening of tonight's speaker series, it's my honor to invite State Secretary Dr. Thomas Steffen from the German Federal Ministry of Health to the stage. The success of the WHO Hub would not have been possible without your commitment and support to the Hub. Dr. Steffen has been an instrumental advocate for the WHO Hub, offering guidance and support that has been pivotal for the Hub's success. Dr. Steffen, many thanks for being with us tonight and for invaluable contributions to the WHO Hub. And ladies and gentlemen, I welcome Dr. Thomas Steffen.
Yeah, many thanks, Oliver. Ladies and gentlemen, distinguished guests, all, it's good to see you tonight. Also good to see the former Health Minister of Germany, Hermann Gröhe, being with us tonight. It a little bit illustrates the huge interest that we all have in the work of the WHO Hub, located here in Berlin. I don't know how you feel about the current situation from a global perspective, also from a national perspective, from a European perspective. My impression, just coming back from Brussels, is that we are all together, I would call it, traveling through troubled waters. And the best thing you can do, be in a ship, traveling through troubled waters, is that you can stay the course. And in my view, this is exactly what the WHO Hub in Berlin here now is doing. You are staying the course, and you are fulfilling your mandate, which is more than important in today's times. And also very much like the idea from time to time to organize a kind of, you call it, open house tour, which you did today, because traveling through troubled waters means that others will travel with us. And we have to convince others not to leave the ship in troubled waters. And this is the best way forward to create transparency about what you are doing. And this is exactly about the open house tour that you organized, and you should organize it again in future times and invite all of us and further colleagues to really join you. And in my view, this is a showcase about the hub's work. It's also a showcase about our very good cooperation, the cooperation between the hub on the one hand and the Robert Koch Institute on the other hand, and the Charité, of course, involving as many as possible, but also beyond Berlin and, of course, beyond Germany, because this is not a German hub. It's an international hub. It's an WHO hub, and this is what really matters, Oliver. Since the inauguration of the hub in September 2021, you just mentioned that the WHO hub has seen remarkable growth. And just to mention one point, and this is the example of the Epidemic Intelligence for Open Source initiative, which I today learned more than 100 countries joined, and of course including my own country and including the Robert Koch Institute, now relying on this kind of technology to detect health threats earlier. A number, the 100 countries, a number that has tripled since the hub's inauguration. This is a success, and this is a very, very big success, Oliver, of you, of Chickwith, and Chickwith's team, of course, and I congratulate you for this big success. The theme of this evening is the role of research in pandemic and epidemic intelligence, as we all know. And in my view, when we discuss the role of research, we should always discuss, since traveling in troubled waters, how we can best and most efficiently allocate our resources, which of course are always limited. And I'm more than happy to have that debate today and tonight, and to strengthen evidence-based decision-making to address global health challenges as efficiently and effectively as possible with those limited resources that we have with us. And in my view, we need the research prioritization. You identified 23 critical research areas to improve public health surveillance, structured along your pillars of better data, better analytics, and better decisions. Or I may add, leading to better decisions than we had in the past, at least sometimes. And of course, I don't want to anticipate our today's debate, but in my view, what we really need is to strengthen multidisciplinary data integration. Second, we need to build trust and really to improve data governance for data sharing. And I have to add, especially in my country, we are sometimes a little bit reluctant to share data. And we really have to realize the chances, which of course is connected and lies with data sharing. And we have to convince others to follow us in this way. And of course, third, we need to bridge research and policies. This is also very important because sometimes I have the impression research is living on one planet and then policy and policy making, this is a second planet. We really have to bring the planets together to make the world a better place. And it's clear, in my view, that researchers, funders, public health experts must align their efforts with public health priorities, collaborating among funding bodies, including national governments, is crucial for ensuring targeted and sustainable support for pandemic intelligence initiatives in future times. And in that sense, again, very warm welcome to all of you for tonight's discussion. And I thank especially the Hub's dedication, and look forward to the enriching discussions and insights during tonight's debate. Thank you very much.
Thank you very much, Dr. Morgan, and very much Dr. Steffen, for your kind introductions to this subject, which is not only meaning we're moving rapidly together, but we're also moving rapidly together through rapids. And the main thing is not to leave anyone behind. It's really a pleasure to welcome everybody in this room and see many people in the room who've also been to our previous lecture series, and a warm welcome to everybody online. Don't feel neglected, although sometimes it's hard to connect in the same way, but we really appreciate that you're all here. I'm Professor Beate Kampmann. I'm the leader of the Charité Center for Global Health, and we're really also here tonight to illustrate a little bit how our academic partnership has thrived in the context of the prioritization of the exercise on research prioritization. The Center for Global Health at the Charité supports the coordination of interdisciplinary research, and this topic needs a lot of interdisciplinarity, as just pointed out by Dr. Steffen as well. And we foster global health research from different disciplines and individuals and institutions with or without within or outside our usual research community, and international institutions, in particular the WHO Hub. Our collaboration with the WHO Hub dates from the 2021 Memorandum of Understanding, and it continues to thrive. Beyond organizing the speaker series today, but also in the last few months, the WHO Hub also supports our Global Health PhD program, which is a new event and a new opportunity for us here in Berlin. And I hope you had an opportunity to maybe look at some of our science demonstrations on the other floors of our PhD students, who are a really talented bunch. And I'm really happy that we have this, and also that Dr. Morgan and others can make active contributions through their lectures, and our students can join events like here tonight. Additionally, we've also been active in the research prioritization effort for pandemic and epidemic intelligence, which has been led by the WHO Hub, and which has inspired tonight's session, and we will hear a lot more about that in the panel discussion in a minute. As already introduced by Dr. Morgan, today we focus on the critical role of research in the pandemic and epidemic intelligence. And as a clinical academic, research has been my life, and I know how much it can bring to all of what we hope is evidence-informed policies, even though sometimes the gaps are hard to close. Such an important topic as robust evidence from high-quality research is vital, also for pandemic and epidemic intelligence, and this is the basis for our effective collaboration, surveillance, and informed public health decisions. Tonight's session will therefore focus on exploring how the researchers and all of us can align our work, and again, the topic of working closely together and being in the same boat has already been touched upon, and how we can improve coordination of the multiple frameworks in which we all work and reduce the fragmentation, which is part of our daily experience. We will examine how to bridge the gap between funding and findings, and also actionable decision-making to drive really impact that is meaningful. Just to give you a little bit an idea about the logistics tonight, we have presentations of two keynote speakers. We will have a panel discussion, and for that, you all have a flyer, because we want you to be active in this panel discussion. It's not just going to be a frontline show, so make use of that by looking at the QR code, which is on the back of this flyer, and you can pose some questions to us. No guarantee that within the 35 minutes we can solve the world, but we want to hear from you what you think about also what the panels are going to discuss in detail. And a digital link has also been shared with the registered online guests, so you can also please all chip in. So with this, I would like to introduce our first speaker, who is Dr. Barbara Tornumbene, who is consultant to the WHO. And Barbara has been the technical lead to put together the research prioritization exercise, and maybe some of you have also seen the details of this brochure, which is very much the framework. But we wanted to give you a bit of more information how this all came about, because this is what we're basing the discussions on tonight, and to which we also have to create now the plan of action to take it to the next step. And Barbara will provide us with an overall introduction to the prioritization process, its key findings, and the next steps in the critical operational phase. Barbara, welcome to the stage.
Thank you, Berta. So let's see. Okay, so in the next 10 minutes, I will guide you through the work that we have been advancing here at the Hub in relation to pandemic and epidemic intelligence. But first, I'd like to start by reiterating the key role of public health intelligence and surveillance. Surveillance is the driving force behind the work that we're doing here at the Hub, and it was also the foundation of this activity. Surveillance is not just a tool. It is the cornerstone, we believe is the cornerstone of pandemic preparedness and response. And it really underpins everything from, helping to assess epidemic dynamics, from developing medical countermeasure to defining control measure to help evaluating the effectiveness of public health intervention. So for this reason, strengthening surveillance is essential to protect the globe from future health threats. And for surveillance to be able to drive impactful decision, surveillance must be robust, reliable, and evidence-based. And this is where research plays a crucial role. But why did we decide to actually embark in this prioritization exercise? From the COVID-19 pandemic spurred a significant advancement in public health surveillance and the related research. But when we look at the research environment, we found fragmented funding, siloed research, we found insufficient translation of research policy, and limited focus of end-user needs. And so the purpose of this exercise was really to bridge critical gaps in pandemic intelligence research to strengthen surveillance, analytics, and decision-making. And the overall goal of the exercise was then to promote a global multidisciplinary research that translates into actionable outcome. And so how did we do that? Well, first, we set up an amazing technical working group with our partners, so Charité Center for Global Health, of course, the Global Research Collaboration for Infectious Disease Preparedness, or GLOBIDA, the Wellcome Trust, and the WHO Science Division. And then we went ahead to define a 4-step methodology to bring this exercise to life. So the first step, we use it to identify our objective. The Child Health and Nutrition Research Initiative methods was chosen. I don't know if you're familiar with it, but it's been used broadly for research prioritization. And then we designed a framework to use for our global expert consultation. And as Beata mentioned before, and Dr. Stefan, the framework was based on better data, better analytics, and better decision, which is also aligned with the focus of work of the Hub. Then we move ahead and we conducted a global expert e-survey to identify research gaps and problem statements related to pandemic and epidemic intelligence research. Initially, we identified 160 global experts, assuring a combination of professional expertise and representational balance. So we had epidemiologists, data scientists, but also experts in system thinking and infectious disease epidemiology and One Health, but also social science, behavioral science, translational science. And we wanted these people to have experience in analyzing health data, but also in the application of research finding for decision-making and in health research and practical policy implementation. Overall, the group reflected a balance of gender and sector, private, academia, public, and a geographical representation based on the WHO 6 region. So of these 160 experts, 83 generated 803 problem statements. Those statements went through data cleaning, and they were analyzed using a qualitative approach, which is framework analysis. And the refined statements were then transformed into 23 research topics through a long iterative process that was led by technical staff here at the hub, but also at Geneva-based emergency program, and by, of course, the technical working group. So these 23 research topics then were scored against 5 priority criteria by 45 among the 160 experts that we had contacted initially. And this allowed us to basically calculate what it's called priority score and ranked the statements as you will see them in the technical brief. But aside from scoring the research statement, we also grouped the statement amongst 8 thematic domains, which I've listed here. And this is because we felt that, surveillance is a process. So, it's everything from data to analysis to decision-making, all backwards, so what from decision-making needs to the analytical and the data needed to respond to these needs. So we felt that by grouping the research in these domains, we allowed for a more organic representation of the statements among the 3 pillars: better data and better analytic and better decision. But this spread also, I think, underscore the complex nature, actually, of research for pandemic and epidemic intelligence. So here I've just listed the 8 domains. Of course, we had AI and technological advances. One example is, for example, research into multiplex cost-effective diagnostic for point of care, or using AI to enhance outbreak detection. We had research related to data preparedness. So, for example, investigating a better understanding of data value chain. We had statements related to quality standards, so research into methods to evaluate the effectiveness of our response. And of course, analytical frameworks, so research into potentiate real-time forecasting or accelerating data analysis. A critical gap also that emerged during our consultation was the need for a more effective multi-sectoral approaches. So, and here we have research that looks at multi-sectoral approaches not only for data collection or data validation, but also for collaboration into decision-making, so bringing people from diverse sectors when we need to make decisions. Another critical insight were community-centered approaches, and again, here we're looking at research spanning from gathering community data to identify vulnerable population, for example, when we think about response, or to collect data from community sources like citizen science data. The last 2, governance, we have research looking, for example, at ethical and legal consideration for surveillance and evidence to policy. So, for example, research to look at how to better communicate health risk from researchers or scientists to decision-making. So moving forward, we're now starting to develop our implementation and M&E strategy. This is based on 5 deliverables. Those are mirroring the existing objective of the prioritization exercise. And so we want to make sure that by defining this priority, the focus of research will be more on public health practitioner priority, that this statement will offer a structured research landscape for the academic and research community and to guide collaborative effort across the discipline. And the lead for this implementation and M&E strategy, which is targeting research and academia moving forward, will be Charité. The 4th deliverables is related to funding, and this is about using this statement to guide funders to ensure adequate and targeted financial support. The target, of course, of this work is going to be funding bodies and donors, and the lead for this work will be Glopida through the Pandemic Pact. And finally, not least, but the last deliverables is related to making sure that the outputs of these 23 research priorities is actually accessible to public health practitioners, especially when they make decisions. So the target group for this work will be public health practitioner, decision maker, maybe policy maker. And moving forward, the lead for this work will be the team here in the hub. So with this, I thank you for your attention. I put the QR code for the publication, which is also available in hard copy somewhere there. And I hope you enjoy the rest of the session. Thank you.
Thank you, Barbara, for providing us an excellent overview also over the process. So it's not a question of putting your mates in a room and then say, okay, what do we do tomorrow? And then one person makes a decision. So a really thorough process there. Now I will introduce our first keynote speaker for tonight, who is Professor Stefan Flasche, a good colleague of mine from the London School originally, and now with us here at the Center for Global Health. Professor Flasche is an Einstein-Berlin University Alliance Professor for Infectious Disease Dynamics and Global Health, and he holds a part-time appointment also still at the London School for Vaccine Epidemiology. Vaccine epidemiology has been a focus of his work, in particular around global immunization strategies, but he's also got a long-standing interest in disease transmission. And while a significant portion of his research has concentrated on pneumococci, Professor Flasche has a keen interest also in outbreak response, AMR, RSV, and even dengue and malaria. There are things on here, Stefan, I never knew you did. So I'm now very pleased to ask you to come to the stage. And the thing I haven't mentioned is you're also you're also a member of the standing committee of the STIKO at the Robert Koch Institute, and that's a really important part to get our evidence into practice. Thank you very much for coming and giving us your thoughts, Stefan.
Thank you, Beate, and thank you to the organizers for having me and giving me the opportunity to share some thoughts about the role of research in pandemic and epidemic intelligence from my perspective, which is that of infectious disease dynamics researcher, data analyst, if you want, spending most of the career, so far at least, in the UK. So bear that in mind. Let me start with the first example. Being swine flu, most probably remember that. At the time I was in the UK, and part of the pandemic preparedness plan in the UK, and I believe elsewhere as well, was paying notion to the fact that it's important to understand early on not only the clinical features and the clinical severity, but also the transmission dynamics of a pandemic that we may need to mitigate. And for that, they set up what's called the FF100, first few 100 cases that were meant to be monitored very closely for who transmitted to whom and all sorts of infectious markers. And there were two teams that had access to this very detailed data, and they were meant to work independently as a kind of safety net assurance or quality assurance. And so, well, that's what we did. So we basically created situational awareness. We understood as much of this new strain of influenza as we could. And then as we went along with our analysis, what happened was that we slowly realized that the severity of that strain of influenza wasn't actually that bad. It wasn't much worse than a usual seasonal strain. And also, shortly after, the school holidays came into place, and so actually infections went down again. And so then as academic, we used that quiet phase to try to repin some of the academic credit of having done the work. We then had to concern ourselves with, well, how do we actually make this work for our own career? And so that's where we encountered a real problem, which was that it's all good and well that you have two teams looking independently at the same data, but that's not really how academic credit is set up for. It's not really set up for teamwork. It doesn't incentivize teamwork. And so we spent a couple of weeks arguing over authorship, by which time we then eventually published a paper into a journal which doesn't even exist anymore. There you go. But this is to highlight that there's some mismatch there. But it's also to highlight that, well, with this work specifically, we didn't really have an awful lot of impact because we didn't influence any decision making. It was just situational awareness at the time. There wasn't any academic credit really, but nevertheless, it was very important work because things could have easily gone another way, and then we would have really needed that situational awareness. Well, at least some impact was had in that we had developed tools so that next time we'd be slightly better prepared. And so, well, a number of years later, when the Ebola outbreak in West Africa came along, we had those tools at our disposal. And so when we were approached by MSF to help them better understand the situation and particularly help with forecasting of bed demand, treatment bed demand in West Africa, we could relatively quickly turn around those old tools together with insights from the ground and the data that was collected into a forecast for bed demand, which, well, at that time MSF hadn't really appreciated, and which was predicting that it would very quickly exceed what they had originally planned with, and to, well, adjust plans accordingly. So here's an example of research that had quite direct impact very quickly. But, well, I said research, but it's actually debatable whether it's research, because the tools were there, the data were there, we just kind of applied it. And so that's why, well, having this capacity in research to react to this then doesn't necessarily lead to more research, but it can still be important work, particularly in the context of a pandemic. Okay, so I had to mention COVID, of course, as a third case study. And so one of the main things I personally took away from COVID and the response was that we as a scientific field, scientific community, really struggled to evaluate the trade-off of preventing transmission with the costs of, well, the social impacts of that prevention strategy. It was relatively obvious where that trade-off was early on, but as that became less and less obvious, we really struggled. It was, well, from our end, what we did, we quantified the costs of doing nothing in terms of hospitalization and so on, but the societal costs weren't really part of the equation. And, well, but instead what we did was we tried to do research in a direction that would help preventing transmission or mitigating transmission while minimizing the societal costs. And so in that case, we were approached by an ex-master student of a colleague of mine who found himself, relatively surprisingly, in a rather senior position in the Ministry of Health in Slovakia. And in Slovakia, they've done, well, at the time, a completely unparalleled intervention, which was they tested more or less the whole population twice against, well, for the presence of COVID with a rapid diagnostic test, which at the time was, well, not very well accepted because it wasn't perfect. It was quick, but it wasn't perfect. And so he approached us with the need to help with the analysis to see how well this worked. And so we dropped what we were doing. And I mean, I'm saying this lightly, but in an academic life, that's actually a bit difficult because much of the funding we're working on is short-term funding with some very clear deliverables. And so, well, for myself, I was really lucky in that position because I was funded by a fellowship for the development of my career, but without any clear deliverables. So I was basically able to do my own priorities, which enabled me to actually do that kind of work. And so we looked at it and it became very clear quite quickly that there was some real scope in using those rapid tests, whether it would be in terms of mass campaigns or otherwise, but they worked if used at scale as a mitigation tool to curb transmission in a much nicer way than a lockdown would do. And then we went on and well, did some more research in that direction, and eventually also showed that you could even potentially skip quarantine if you tested daily following a potential exposure, and you tested negative every day. So you may remember there was a time when you had a potential exposure, you just needed to stay home for 7 days. And we showed that with rapid testing, you may not need to do that. And so both of those studies went very quickly through the pathway of evidence to impact in the UK. So there's a committee called SPI-M, which was composed of a number of modelers. And so basically on the day we finished the analysis, it was presented there. And the next day it went up to the main SAGE committee, which was kind of in direct contact with the government. And so both studies had, contributed quite substantially to the overall evidence base that then informed their decision making on how best to use rapid diagnostic tests. And also luckily, we were able to then publish this work in high impact journals. But of course, the timeline was such that the impact was done way before we even started the publishing process. And the main impact for us as scientists, other than having a high impact factor publication, was that we got a lot of angry emails with people who disagreed with the policies that were put in place. So again, a bit of a mismatch there in incentives. And so to summarize this a little bit, and I have touched only shortly on this, there wasn't any funding for any of this work. So there was, of course, a lot of funding for COVID and a lot of COVID research, but for these pieces of work that I presented, there was no funding for it. And I would also go as far as say it's basically impossible to fund that work in a kind of reactive fashion, because it's basically always seeded by an acute thing to look at. And so we don't have those kind of mechanisms in academic fundings to do this. I don't have a solution for you, but I have a problem. The other part is, and I mentioned this a bit more, that the academic reward structure doesn't really match up incredibly well with impact of our work. And it's even worse during a pandemic. And so, I mean, in terms of the timeline, what I highlighted here is that, well, it may have gotten better, at least as I went through my own personal timeline, but please don't take that away from this talk, because that was just how I picked the examples. In fact, quite a number in our team in the UK at the time worked really hard and did really crucial work as researchers, but in a way that they were not able to rake in the academic rewards, which then caught out their careers at the end of COVID. So if we want to make best use of research and the impact it can have on our pandemic response, then we need to really try and align those two things a bit more closely. And it's quite shocking, particularly how some simple measures like the impact factor play a role in many countries still. Okay, so enough on enabling research. I want to use the last 1.5 minutes I have on making that research visible and thoughts about that. And so this is a statement that was the theme of a recent meeting that we had, I think exactly here. And it was about modeling, how to get modeling to impact. But I think this statement is basically one-to-one translatable into research as a whole. And it offers a couple of conditions that help getting research into policy, or at least being heard by policy. But I want to focus on the accessibility part. And so caveat at the start, there's a difference between policy having seen good research and a policy being the right one. So I'm not saying that necessarily the UK is the best country in the world in terms of their policies, but I think the way that modeling was included in the policy process was actually quite a nice one. The way it was built, and I mentioned this very briefly earlier, was in the main SAGE committee. It was the main scientific advisory board to the government directly. There was some modeling capacity in there and a number of fields as well. And so it acted as a highest level filter of what are the key things that we need to communicate to decision makers. But below that, there was a number of other additional committees, and the modeling committee called SPI-M, and that was very inclusive. That included 83 modelers quite early on, in order to reach as much of the scientific community in that field as possible. But even that was another part of a filter. So it's basically like a two-filter process to distinguish between the noise and the signal, because there's also a lot of noise. And well, I think while I have great hopes in the role of AI in research and to make it more accessible and to make it quicker, it will also create a lot more noise. So these kind of filters are going to be very important going forwards. The key thing here, though, is that this setup was not designed as we started the pandemic. This is a long-standing setup, not with the number of people involved. And obviously, during the pandemic, these panels have met a lot more often. But this is a standing committee that advises governments, builds trust in the relationship between academics and governments. And I think that really played off well as well. We went into the pandemic and it was needed. So I'll close with that and just leave a couple of discussion points that I mentioned up for your own interest. Thank you very much.
Well, I shall reserve my comments on some of the filters in that system. But thanks very much, Stefan, for sharing the vital role of research in pandemic and epidemic intelligence and elaborating these examples from your own work. What I would not want people to go away with is thinking that groundbreaking research can be done without funding, because you just showed these examples that were done literally on the back of envelopes that were already existing. And I think it's absolutely crucial that we emphasize that the only reason why this was possible was because there was funding. And I'm afraid Dr. Steffen's just left. That's a bit of a shame. But anyhow, maybe I'll watch the recording. But, you know, without filling the pipeline with the funding, this isn't going to happen. And the freedom to, or the opportunity to have the surveillance going in the way that we need it is absolutely relying on the ground of the funding being there, because, as you've also said, reactive stuff at the time of an emergency is never going to cut it. And that brings us to the funders very neatly, and I'm now delighted to introduce Dr. Alice Norton, who leads the Pandemic Sciences Institute's Policy and Practice Research Group at the University of Oxford. She and her group undertakes applied research on the design and implementation of policy and practice for pandemic preparedness and response. She's an academic and policy lead also for the Africa Pandemic Sciences Collaborative, but tonight she's mainly here as the head of research and policy team for the PSI of the Global Research Collaboration for Infectious Diseases Preparedness, which is quite a mouthful, called GLOPIDAR. And she's conducting research and policy development to support the funder decisions in this space for their preparedness and response to infectious diseases. You're a member of the technical work group for the research prioritization, also of the pandemic and epidemic intelligence here, so you've very much contributed to the 23 priorities that we've set here. And we are now really welcoming you to the stage to tell us how the funders that you somewhat represent will take this forward. Welcome to Alice.
Thank you, Beata. So I think I'll probably start with the disclaimer that I do not purport to represent any funder, especially in my statements now, but I certainly do support them with information. I've had a mixed career of being an infectious disease epidemiologist, then being a funder at the Wellcome Trust, and now I study funders in the same way as I did as an epidemiologist. So that's what you're here tonight. So I'm just going to give a few reflections around this topic and around examples I've seen as to how we can potentially address the fragmentation that we see in the funding system that leads to suboptimal coordination of research and therefore translation to impact. And there are many things that can be done and that have been done in this area, but it's absolutely true that more needs to be done, particularly in the topic area that we are discussing now. So a lot of the reflections I'll give to you are linked to our work in support of GLOPIDAR. So for those of you who don't know what it is a coalition of global research funders, 35 of the biggest sort of funders you'll have heard of around the globe, and some key observers such as CEPI, World Health Organization and such like, who have come together as a collaborative to try and solve some of these problems of how we improve coordination and coherence, really, of the research response, both in preparedness, as we're seeing, as we're hearing, really those investments need to be there before an event, but also in response. So I'm going to look at various different aspects of the research process and how we've looked at fragmentation in this case. So research prioritization, that's the kind of basis of why we're here today, and it is absolutely core, that setting of the research priorities across which and alongside everyone can align. And therefore, obviously, the process by which those priorities are set is equally important, both for the fact that they might align the community to the correct priorities, whatever they might be, but also the process is really important in terms of engendering trust and confidence in the community to actually implement that prioritization list that's brought out, such as the one that the Hub's just done. So we did some work with the Global DAR funders after the pandemic to look at their experiences of how they had, as funders, managed to prioritize their investments. And we learned quite a lot of lessons from that around their restrictions, around the fact that some of them had to align due to their existence and the way in which they're set up to nationally set priorities. Other funders managed to align to global priorities, such as those set by the WHO. But as a group of funders, what they really kind of learnt from this was that in order for them to convince their bodies, their funding organisations, to align to a set of priorities, there had to be some key components in place. Really core to that was that the process to set those priorities were transparent. So that's why it's so important to hear that detail from Barbara just now. That the idea that a systematic process has been used, that the fact that there's inclusivity in the voices, the fact, obviously, in an outbreak situation that these priorities are updated rapidly, and also then the importance of putting in feedback loops and ensuring monitoring and evaluation of priorities which clearly change within an outbreak situation. We've then done some further work on this, doing a kind of scoping review of what's out there, published, about research prioritization processes in this field. And what it really shows is that while there are examples and guidance on best practice, these are rarely followed, and the transparency in the process is rarely there. And the thinking is that this might contribute to the lack of alignment to these priorities. And so it's great to see, many of these things have been addressed in this process here. Another thing that we learnt during COVID was, which, again, we're talking about surveillance, was that really, in order to align funding, one needed full visibility, so surveillance of what funding was going out there and what that research was on. So we worked between a UK group of funders called UKCDR and Global DAR to set up a kind of global monitoring system of the research that was being funded during COVID. We called this COVID Circle, and we aligned that research to the WHO roadmap for research prioritization to see how well the funding was aligning to the priorities, where the gaps are, where the opportunities were. And then we did a lot of sort of research and analysis around that to identify gaps in, for example, alignment to research priorities of particular importance on the African continent, gaps, for example, in terms of a very slow uptake by funders, the realisation of long COVID as an issue, and then we fed these into then future prioritisation exercises, which there were a proliferation of during COVID, to try and help support that kind of incremental prioritisation of what was really necessary at the time. What we learned from that was that this was quite a useful thing to do. People found it valuable, and we've built from that a new programme which is called Pandemic Pact, which is trying to do that prospectively. So the research funders really said in the first 3 months of funding, they really wanted to get funds out really quickly during COVID, but those few months where there wasn't actually a global prioritisation process in place and where they really could not keep track of what each other were funding. So what we've set up, therefore, prospectively is the tracking of the funding aligned to the WHO list of priority diseases so that transparency is built in, and we have those systems in place already in terms of monitoring that landscape to then react to outbreaks. So then we've pivoted this, obviously, recently for Mpox, for H5N1, and for Marburg to really kind of update these analyses rapidly to give that picture of where the research gaps may be. So all of what I've been talking about, the idea of setting priorities, making sure that they are well set and they're going to be followed, the idea of monitoring investments so that one can coordinate by looking at what the landscape is and where the gaps are. All of those are still slightly down the pipeline than we could really be in the funding system. So there are some examples in other disciplines of effective coordinated funding mechanisms in existence. The Global Alliance for Chronic Diseases does this. It's a group of global funders who come together to set shared research agenda globally and then fund those in a coordinated way in order to support those international collaborations between researchers. JPAMR is another one in the AMR realm, and GLOPADAR is now starting to develop plans to move into this area as well in the near future to develop an aligned and more coordinated funding mechanism to support this. The idea, therefore, being that this might, get ahead of the scale and prevent duplication early on. So hopefully it's a natural progression to then sort of say that what we are now doing in support of the research prioritization for pandemic and epidemic intelligence. So some members of my Pandemic Pact group have been working very closely with Barbara and colleagues to look at how we can align what is in this roadmap to the funding tracking that we are already doing through Pandemic Pact so that we can monitor the investments against the roadmap and again give that kind of clear indication of the instigation of research. That's only part of the puzzle, though. Funding is the start of something. We've already heard from Stefan that actually what academics do with their funding can often be quite different to the purpose for what that funding was made. And that is, in many cases, absolutely brilliant. So therefore, kind of very clear that whilst this sort of solves part of that puzzle of monitoring, it isn't the whole picture. And what absolutely then has to feed back into these prioritizations is where the evidence is advancing. And we are, again, through this program, taking some steps towards that. And this is a kind of nice map of how that's sort of looking against our themes that I will not leave there for long because it's too detailed. So thank you for your time and thank you to funders.
Thanks very much, Alice. This was really insightful, and I think there's consensus, coherence, and coordination that you've brought to the forefront of our minds here, which is probably ingredients that we could all do with. Okay, for the panel discussion, we'll be joined by a few more panelists now to bring in the view from researchers, funders, as well as policymakers. And in addition to Alice, please join me on the stage, Dr. Ifedaya Detifa from FIND, Professor David Heyman from the London School of Hygiene and Tropical Medicine, and online we welcome Dr. Natusu Imai-Eaton, who is the research lead in Infectious Diseases Strategy Program at the Wellcome Trust. And I also welcome Oliver back to lead the panel discussion. Thanks.
Great. Well, thank you very much, Beata, and thanks very much, everybody. We're now into the discussion and panel session. So let me just remind everybody that they can submit questions through the QR code if you're here. And I think the link has also been shared with colleagues who are joining us online. And Natsuko, we can see you. So welcome. I'll just briefly introduce the panelists who joined us. We have, let me just reorder so we can go from the very end. Let's start with David. So Professor David Heyman is a professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. And David's held key leadership roles in WHO from 1989 through to 2009, including overseeing polio eradication efforts, and as well as working on smallpox eradication in India and investigating the first Ebola outbreak in the Democratic Republic of Congo. We have also Dr. Ifedayo Adetifa, who's the Chief Transformation Officer and CEO of FIND, which is an NGO dedicated to diagnostic innovations. And Dayo has previously served as the Director General of the Nigeria CDC. Welcome, Dayo. Alice, we've already met. Welcome back on stage, Alice. And on screen joining us is Dr. Natsuko Imai-Eaton, who is the research lead in the Infectious Disease Strategic Program at the Wellcome Trust and oversees research investments in epidemic preparedness, surveillance, and pathogen genome sequencing. And Natsuko has previously spent 10 years at Imperial College London working on outbreak analytics. Welcome, Natsuko. So why don't we kick off the discussion with a few questions to our panelists. And David, maybe I'll start with you. You have a vast amount of experience from a number of different perspectives in this space. And it'd be really interesting to hear from you whether, from your vantage point, you think that decision makers are actually better placed to take advantage of research outputs when they're responding to acute public health events now. Is the situation improving, or are we still kind of in the same space as we have been for several years?
Thanks. Are you here?
Yes.
Thanks, Oliver. In fact, countries in Asia have been prepared for things like the COVID-19 outbreak since 2003, after they built up systems of rapid detection and response. So they were ready when COVID came, and they began immediately in January stopping outbreaks and letting the virus enter quite slowly so it didn't overwhelm their systems. Whereas in many countries in Europe and North America, it was watching and waiting. However, there were many countries that were prepared as well with evidence. I think the UK, we heard earlier, was quite well prepared. And in fact, they weren't prepared in the epidemiology sense. They weren't able to stop outbreaks or detect them immediately. But immediately, they put money into research. And I actually chaired a committee that reviewed every week proposals that came in that could be completed within a period of 12 months that would contribute to outbreak control during pandemic. So they immediately put money, and I think Alice could tell how much was put into that, but quite a bit of money. And in addition, they had established the Jenner Institute with Wellcome Trust and others that was already working with vaccines for coronaviruses, and they were prepared to develop a vaccine. So preparedness was mixed. In some areas, epidemiology was stronger. In other areas, research was stronger. The countries were prepared, and I hope that now other countries will have learned from those examples.
Great, thanks so much, David. One of the kind of actually the first priority, that's highest ranked priority, I should say, in the prioritization exercise that we've conducted for pandemic and epidemic intelligence, really focuses around improved diagnostics, especially diagnostics for across multiple pathogens and diagnostic technologies that can be used closer to patients. Dayo, could you share some of your experience about the importance of that and how we could perhaps think about this in a more structured way?
Thank you, Oliver. Well, I think it is a relief to see the attention given to diagnostics in the research prioritization document. Early outbreak detection, response, surveillance, and even the assessment of the impact of public health interventions all require diagnostics. And often you find in public health, in research or even in budgets, diagnostics are often neglected. And the COVID pandemic really painted a bleak picture in terms of what happens in the diagnostic space, especially in the less resourced parts of the world, and perhaps in the more peripheral levels of healthcare and in the community. And it is this gap at the moment that institutions like FIND and working with partners, this is where we target our effort in terms of trying to achieve or push an agenda for diagnostics for all. It's, as I said, it's heartening to see more conversations around diagnostics. But I think it's important to sort of highlight that despite the experience from the COVID pandemic, that we still have significant gaps where we've got the viral families approach championed by WHO. But when you look at that, and of course look at FIND's published pathogen diagnostics index, many of those viral families or pathogens have no tests at the moment. And for those that have some ongoing work, the R&D pipeline is completely empty. Okay, and when you paint you look at that scenario against a backdrop of the Lancet Commission on Diagnostics that already shows that only 47% of the world truly has access to essential diagnostics, you get a sense of the challenge that still remains in that space and how we cannot overemphasize the prioritization or conversations around diagnostics.
Great, thanks so much, Tayo, for outlining some of those challenges there. I'd like to turn to Natsuko now. I hope you can hear us okay. Natsuko, you work at the Wellcome Trust, which is one of the largest funders of medical research in the world. And I would be very interested if you could just share from your perspective some of the challenges of identifying which research topics are the ones that are the kind of, I guess, most impactful, and how do you go about maybe assessing what the impact of that research might be in the longer term?
Sure. So thanks very much for the question, and I'm very sorry that I'm not able to be there in person. So I think in terms of in the context of epidemics, and you sort of highlighted that we're a medical funder, and I should highlight that Wellcome really does focus on research, and so there are elements of priorities within that perhaps Wellcome aren't able to fund, and so within that it's very important, as Alice has already highlighted, to be able to coordinate with all other organizations that are involved. And so really no single funder organization has the resources or really necessarily the relevant expertise to effectively fund across every discipline that is crucial for pandemic and epidemic intelligence. And so we do really rely on, for example, the process that Barbara highlighted earlier, which is really this co-developed piece of work to be able to understand what are the crucial pieces of research that need to be funded, and then also, where is, for example, from Wellcome's perspective, where could we best contribute? And so, for example, Wellcome may not be able to directly fund, for example, pure implementation research, but then therefore it's important that we're able to closely coordinate and align our investments. And we do this really both bilaterally, for example, with FCDO through our joint initiative of research and epidemic preparedness and response portfolio. And that really includes not just epidemiology and clinical research, but also social and behavioral sciences. And so just in terms of, your second part of the question about how do we make sure that the impact is measured over time, I think it's a reliance also on this feedback process and the transparency that's been highlighted by the other speakers already, just to be able to make sure that we have that agility to always be listening to what is the priorities that are coming out from those affected regions.
Great, thanks so much. Yes, I think I'm back. Thanks so much, Natsuko. That was great. Alice, in your presentation, you gave an overview about the kind of coordination mechanism of the 35 largest funders in this space, which obviously is a fantastic opportunity to align research investments and also to share research priorities. Can you kind of just explain a little bit about, maybe some of the kind of geographic scope of this? And, David mentioned that, there's good kind of research preparedness, might call it, maybe in Europe and Asia and other parts. but presumably there are other parts of the world which might not have, such a opportunity. How is some of this research funding geographically distributed, and how do we manage a kind of research from like a global perspective?
Thanks. Yeah, very interesting question, Oliver. So in terms of the membership of Globadar, it does have global representation. It has members in every continent, but it is heavily biased towards North America and towards Europe. I think what's also worth remarking on that is that the types of funders really do differ globally. In some areas we have charitable foundations, others we have sort of research funding organisations with governmental funds that are at arm's length to those governmental funds that are, running calls. But actually what happens in many parts of the world is that actually the research funding is more through national institutes and it's core funding. Those types of countries with that type of funding often don't consider themselves to be research funders. So therefore, whereas they might want to join in these discussions, that they aren't always, at the table. And I think that's a really important consideration. One way in which Globadar's look at this is through the idea, as many global organisations are now doing, of regionalisation and regional hubs. And that idea that at a regional level, the discussions between these different entities might be more relevant.
Yeah. Great. Thanks, Alex. Actually, maybe Nansuka, maybe if I can just jump straight back to you on this kind of regional question, because I know this is something that we've discussed in the process of the prioritization work that Barbara presented. Do you, in your experience of looking at a large number of research kind of proposals and having a large number of research initiatives, is there a lot of geographic diversity, a lot of regional diversity? Is this something that we should be really worrying about or focusing on, making sure that there are regional priorities that are being addressed?
Yeah, thanks for the question. And so I should say, although Wellcome is a global funder, we are based in the UK. And so historically, a large proportion of our portfolio is, UK based. There is, a very strong push now and obviously a huge recognition that the research needs to be diversified both in terms of disciplines, but also, of course, in terms of geographies. And so we are increasingly seeing proposals and funding research directly in countries that are most affected. I think when we balance, say, for example, if we have an open funding call, we do integrate or make sure that within the scope of the call, we really emphasize that inclusion of both multidisciplinarity, but also multi-country studies. So, for example, we just had a dengue Zika funding call out this year, and very much one of the key criteria of the call was that the teams had to include either a co-applicant or a lead applicant or stakeholders from dengue Zika affected countries. And so, I don't think it's going to be overnight, we won't be able to change that sort of distribution that is, as Alice says, currently biased towards the global north. But I think collective efforts are really important to be able to shift that dial. And then another thing I would say is at Wellcome, there are different ways that we fund. Some are open funding calls, but we also make very strategic directed investments. So, for example, our Africa and Asia programs are long-standing investments that we have that are, research programs that are embedded within country. So, for example, in Malawi, Kenya, Vietnam, Thailand. So those are, really, really important to build that research excellence in different regions. And then finally, we do work directly with some principal investigators through discretionary awards and really co-develop very strategic awards. And obviously that's not necessarily as scalable, but I think it's also really important to recognize those, recognize and address those very specific regional priorities.
Great, thanks so much. Thanks so much. Oops. Yes, I'm back. I'm going to say thank you one more time. I am English, so saying thank you is no problem. David, maybe I can just switch a little bit and really kind of hear. So I'm going to start picking up some of the questions that we've been receiving online. And there's been quite a lot of interest in how does research really, what's the pathway from research into decision making, like in a kind of response setting, and how does that work, and how can we make it work even better?
The pathway is sometimes very difficult, but at other times it's very easy, because many times there are challenges during an outbreak or during a program when there needs to be a modification made. I'll give a couple examples. In the smallpox eradication program, there was a lack of vaccine. And so there were attempts to develop new strategies to use the vaccines, and they did develop a strategy. Instead of mass vaccination, they focused on ring vaccination, conserving vaccine, vaccinating only people living in the neighborhood of the person who was infected, and the contacts. The same in polio. Polio eradication faces several difficulties. One of those was a vaccine that was not working in some parts of India, for example. And children with polio had up to 12 vaccination doses and still were becoming paralyzed. The literature was reviewed, and it was found that already in 1970s, the answer was there. There was competition between the 3 viruses in polio vaccine. Separating the vaccine into 3 different vaccines solved that problem. Other problems have occurred since then. But challenges during an outbreak or during a program are what really can drive research, and good research as well. During the pandemic, lots of good research. When the PCR was no longer, was not able to get to the most distant parts of the countries, then the lateral flow tests were developed. So challenges during outbreaks are very important, and it's a shame that they can't be transcribed into preparedness. But for the moment, they aren't so well transcribed into preparedness.
Maybe I can just kind of follow that with a question about, well, how can we maybe formalize some of those learnings that we get during epidemic response, and use those opportunities to conduct robust research for future preparedness. Any initial thoughts on that?
Well, CEPI has been set up to do that in the UK to help develop platforms. FIND has been set up to look at diagnostic tests and work. There are many different innovations that have been created since outbreaks have occurred, and hopefully more will develop as time goes on. But it's the direct challenge and the real need that drives the research.
Thanks, David. Dio, you've been at the sharp end of many responses as well. Recently, certainly as the director of the Nigeria CDC, most recently. What are some of the challenges that you face in kind of accessing research outputs in the heat of the moment?
So if I back up a bit, so I started off COVID response using the pandemic based while I was in Kenya, and then of course after Chukwe had to go to Nigeria and also then continue with that. So there's slightly 2 different flavors to that. So I think very clearly the ability to mobilize resources and pivot very quickly to generate the research data needed to inform contextual outbreak response was a challenge. So the funding schemes were not there, domestic funding wasn't there, ethics committees were not didn't have any experience with quick IRB reviews and all of that. And of course there's the misinformation and all of that. So that created 2 problems. One, you didn't have the data you needed to inform decisions. So clearly there was an overreach in sort of how lockdowns were implemented, and school, Kenya lost, 18 months or basically an entire school year. And of course, in many countries, the socioeconomic disruption still reverberated for months after the acute phase of the outbreak. You then, of course, as a consequence of a pandemic, which is a worldwide challenge, there were sort of not enough diagnostics available, supply chain challenges, and all of that. So you couldn't even deploy the tools that you required to help with sort of a detection and everything else that you needed beyond that. The third thing to highlight is, and this is related to the point David mentioned earlier, we need to have pre-pandemic, or as part of preparedness, we need to have robust R&D ecosystem, okay? So we were lucky in Kenya, and again, thanks to Wellcome Trust's funding at Kemri, is we developed a serological test. Colleagues developed our own in-house serologic test based on data already published by people in the United States. That's not something many countries or many public universities or institutions could do. So at least that put us in a position to quickly track how this virus was spreading through the population. So this is a long-winded way of saying that unless we put in the preparatory work, we will continue to experience the challenge of conducting research and even deploying the benefits of research in the context of any outbreak response. And, right now we're talking about the 100-day mission. There's a whole spectrum of significant amount of work that needs to be done before day zero. There's very limited funding for the 100-day mission. So all of that background work that needs to be done to, fill your R&D gaps or even achieve synergies between the development of vaccine therapeutics and diagnostics for priority pathogens is just not happening yet because the funding is not available. So sorry to be a bit gloomy.
Great. Well, no, realistic, I think, is what we're going for. Thanks, Dio. Natsuko, maybe I can address a question or ask your perspective on a question, which is that, within the research priorities that we've collectively identified, some of them are, if not new, at least maybe not the traditional ones. So, for example, engaging with citizens or citizen scientists, or having members of the public's input more systematically captured as part of understanding infectious disease outbreaks and infectious disease response. How, as a funder of infectious disease research, are we seeing a kind of a change in perspective from the biomedical to almost more sociological perspective of what research is needed?
Yeah, thanks for the interesting question. So, I think, and I'm not a medical doctor, or I've not been in the field. I'm not a field epidemiologist, but my sense from working on outbreaks is, even if these data that we might classify as novel streams of surveillance data haven't been formally integrated into surveillance previously, I do think they have informed how countries and local stakeholders respond, whether that be a community healthcare worker will give you some slightly more qualitative information that may not necessarily be quantitative, and I think we've seen examples of how that sort of slightly more holistic approach has really informed outbreak response. So I think now we're in a stage where it could be possible to really formally integrate that. And previously I was in the modeling field, and we've had a lot of discussions about how can we integrate in a sensible way social and behavioral sciences into mathematical models. And I think we have this ongoing discussion. I don't think we're there yet. How do we quantify what is inherently qualitative data? I think that's a very interesting research question in itself. And so I think we're at a point, and I think the research prioritization has really highlighted that this is really at the forefront of people's minds in terms of how do we make better use of the data that are already available. And I think that's not just sort of technological advances in terms of how do we actually integrate those data, but I think really important to come back to sort of the multidisciplinary aspect is that we make sure that across those disciplines we're talking to each other, because what the same vocabulary may not necessarily mean the same thing in different fields. And I think that's something that for me personally during the pandemic I've definitely experienced. So I think there's two elements. There's the technological research that's important, but also making sure that we are having those conversations to make sure that transdisciplinary conversations happen properly.
Great, thanks. Great, thanks so much. I mean, the transdisciplinary or multidisciplinary aspect is super important. And again, Barbara mentioned it, Beata mentioned it, and it certainly comes out in the research priority exercise that we published. But maybe Alice, I can kind of ask you about cross-sectoral considerations, and you painted, I think, a very encouraging picture of the work for global research funders aligning around priorities and working together. But does that include private sector efforts too? Because there's a lot of private sector research that's conducted, and how can this process kind of maybe extend out to also incorporate investments from the private sector in research domains that are aligned with research priorities?
Yeah, a really important point, Oliver. So obviously the private sector are key and are also similar to research funders and the whole research community looking for optimal solutions to the problems. So there's certainly a shared vision there. There's obviously a different model of operation though, which sometimes can mean that those constituencies don't always mix. I mean, I think there's really kind of great examples of research funding of public-private partnerships that have been really important, particularly in the diagnostic field and such like. In the type of work that we've been doing, which is trying to look at the sort of visibility of research activity globally, to try and help coordinate, then that is actually an issue in that, our work during COVID, we were not able to visualize the private type part of the research investment. So that lack of visibility of what's going on can be a barrier. But there's great successes in more limited partnership that I think need to be built on.
Great, thanks. Dayo, I mean, in the diagnostic space, there are a lot of private sector actors. Maybe from your perspective now, I'd find how can we engage in that private sector research domain as well?
Well, FIND is 21 years old, and I think has a track record really of playing exactly this in this field that you described, of partnerships with the private sector, working with industry, and even following the best practices in that industry in terms of product development or diagnostic product development. If you remember, FIND was involved in the development of the Gene Expert, which is now widely used platform for, well, first for TB, but then following on to that, we also worked quite closely with the same sector in assessing the utility of that platform during the West African Ebola outbreak, and now all of the various products also that have come after that. So it's the way to go. It's essential that we interact or strengthen the partnerships with the private sector. Yes, because there is a difference in the model of work, but I think we find it's been successful in incentivizing the development or attention and end-stage development of even products for diseases that are not as considered either commercially viable or otherwise. And I think we have now sort of successfully exploited that relationship to even achieve tech transfer. So next month, while during the IPD Dakar Centenary, we will be Diatropics, which is commercial or manufacturing arm of IPD, will be launched, and the idea is we have transferred tech for manufacturing of HIV RDTs. The same thing for we have developed tests for schisto, for Neisseria, and for malaria as well, which will be transferred. I think, for example, one of those tests, there's a company in Kenya that's been identified to do that. So it is necessary, especially in the view of all the regional and global initiatives to encourage local manufacturing to, again, bring down the cost of diagnostic tests and make them more available in the places where they are required.
Great, thanks, Dio. We're now wrapping up. We're coming to the final 2 or 3 minutes. I'm just going to go across for each of the panelists to ask a question and put myself in the hot seat. And my question to you in just 30 seconds or so is that the hub is 3 years old. In 3 years' time, what would you like to see us doing so that we can advance this research agenda? What is the role that you'd like to see the hub play? Maybe we'll start with you, David.
I'd like to see the hub understand that where the best alert and surveillance systems originate is in communities. And there are many examples of communities that are reporting, whether it's through animals or through animal farmers or through the community itself. They've been shown to be the most sensitive way to detect and to rapidly respond to outbreaks. So I would hope that the center could focus on communities and using apps and modern day technologies really help communities empower themselves to report when disease occurs so that it can be rapidly responded to locally.
Great, thanks, David. Natsuko, over to you.
Thanks very much. And, I love David's answer. I think really hit the nail on the head. And I think in a similar vein, really thinking about, the research prioritization exercise that has come out, which has, gone through an extensive global consultation. How can you now think about what does that look like really at the local level and now building up from the bottom? And where can we meet somewhere in the middle 3 years down the line?
Great, thanks. Alice, over to you.
Thanks. I think the prioritization exercise, it's a bit of a scary document, isn't it? As in saying, how are you going to have done all that in 3 years? And so in some ways it is similar to David. But it would be great in 3 years' time to see you showcasing best practice. So those communities, those niche areas where progress is being made, that kind of those examples of best practice can then really help drive wider change. So it'd be great to see that in 3 years.
Great, thanks. Dio, your challenge to us?
Two. Was pandemic preparedness, I'd like to see successful One Health approach to the implementation of all of this because we seem to still be discussing One Health in sort of somewhat silos. The second is I hope that in 3 years we actually would then have success of how this implementation of this prioritized research agenda has worked or delivered for diagnostics, for example, of course, representing mine.
Great. Well, thanks very much. I'll take those challenges, and we'll come back in 3 years and see how we get on. So a round of applause to our panelists. Thank you very much. Thank you very much.
Thank you very much. Can anybody? Okay, we're good. Okay, thank you, Oliver, our speakers, panelists, and all the audience tonight, everybody online. And I just would like to give you all a hand of applause because I think this flew really very well. I took away quite a number of lessons, and I think, some of the learnings are generic, but some of the learnings are also very specific for the pandemic preparedness setting. And I guess the transparency and the inclusivity that was emphasized here tonight is something that we need to think about in all the research that we do, in the research exercises and prioritizations, because pandemic preparedness isn't all the research we do. But what's particularly striking is the need for agility and the need for making quick decisions, but in the right way. And what resonated really here at the end is the absolute need, not only to make the money available quickly, but also to talk to people who have to use our decisions at the end of the day. And that's very much the end users, the communities, etc. Because I followed a little bit the questions that were online, and there were a lot of questions about the gap. And there's this great thing in the London Underground, Mind the Gap, and you're all familiar with that. And that's the gap between the policy and the practice and the research and the evidence that we do generate. And I guess, you know, we need to mind that gap by not including the communities who are, in fact, the end users and the end users of technologies as well. So I'm glad that that came out as a very important topic tonight as well. From our side, of course, you know, research and epidemiology belong together. And in our partnership with the Hub, we try and bring to this partnership the research and evidence that we can generate in the Charité Center for Global Health. But obviously, it's a huge stakeholder exercise. And we're, as usual, we're all in this together, and we're all in that same boat, just to go back to what Dr. Steffen said at the beginning. What also struck me is that my priorities might not be the priorities of another 10 people in the room. And when we did the exercise, I think every single person who was supposed to be an expert came up with 10, is that roughly? Yeah, with 10 priorities. So this whole consensus building exercise is really essential to come to some form of consensus, some form of coordination, and some form of cooperation in the end. And with that, really, I think this evening's discussion underlines again the need for researchers, funding, public health experts, and the end users to align their efforts with public health priorities. And it outlines the importance of enhanced collaboration also with the funding bodies, which gives some guidance to where the money should maybe go to ensure targeted and sustainable support for pandemic intelligence initiatives. And we need to think not just at the moment of crisis, it is anticipating the crisis and learning the lessons. So a big thank you to all our audience online and in the room. And we look forward to working with you all to advance this important agenda as we collectively prepare for and respond to health emergencies, and may they never come. Thank you very much, and have a good evening. And for our on-site guests, I can invite you all to the reception. Thank you to the WHO Hub.
We're going to have a obligatory photo.